Hi, and thanks very much for joining us this evening. I hope it's nice where you are. We'll try not to keep you too long, but what we're going to talk about this evening is mental capacity and just give you an overview of what is quite a complicated topic. I'll be doing the talk this evening. I'm Jerard Ross. I'm one of the advisors for the MDU. I used to be a consultant surgeon. I'm joined by Dr. John Dale Skinner, who's currently a GP in practice, as well as being an advisor. And we've also got the head of the advisory department, Dr. Nandasoma, who's going to be corralling questions and putting the questions to the three of us really to try and answer. Talking of questions, you will be able to ask us questions, and we will try our best to get to them. We've got a lot of people signed up, and when I say a lot, we've got over 1,000 people who've signed up for the webinar this evening. That does tend to generate quite a lot of questions, particularly in these complicated topics. So if you are asking questions, try and keep them concise and to the point as you can. Put them in the question box of the GoToWebinar app. There's a drop down where you can type your questions, and we will try our best to get them. Unfortunately, we never get them all, and I apologize in advance for that. If there are any technical difficulties, you can let us know as well, and we've got technical people sitting in the background to try and help. As regards getting information about your attendance, you will have a certificate sent out automatically from the GoToWebinar app after about 24 hours from the event. And if anybody's desperately trying to get to sleep and can't manage, then we do have a recording of the webinar which will be available on the website within the next 5 days. Okay, so with that introduction, I think I'll crack on with the rest of the slides, and Ed and John will be in the background. And I'll pass over to John just about 2/3 of the way through, because he's going to talk about some of the issues that particularly affect GPs and can cause some problems. So let's have a look at some of the legislative issues. Now, we're obviously a multi-jurisdictional defence organisation. We cover the whole of the United Kingdom, all 4 jurisdictions. Today, because of the nature of the law, the fact that the Adults with Incapacity Act applies within Scotland, the Mental Capacity Act, Northern Ireland, applies unsurprisingly in Northern Ireland, we're only going to be able to focus on one of those jurisdictions this evening, and we're doing England and Wales. So we're doing the Medical Capacity Act 2005. Now, there is actually quite a lot of crossover between them, although the acts are different. There's something to be taken from the legislation as it applies to England, because there is a lot of crossover. And I say that as somebody who lives and works in Scotland, so I do deal with the Incapacity Scotland Act. The Northern Ireland Act is although it's been around since about 2016, it's got in progress there on the slide because of the legislative lockdown in Stormont at the moment. Things are not progressing. So only small portions of the act are actually active, predominantly parts to do with mental health legislation as opposed to capacity. So we're going to talk about the Medical Capacity Act 2005, which applies in England and Wales. Okay. There are some basic principles, and importantly, there's also a code of practice, which is nice and thin, as you can see there, and it's available online, and I would recommend that you do have a look at it, because although it's quite a chunky document, it's really well written. The sections are very sensibly laid out, very straightforward to interpret, and I would recommend that you do have a look at it. That notwithstanding, the Act applies to those 18 and over, okay? They're presumed to have capacity to make their own decisions unless it's established that they lack capacity. So that's the first of the principles that we have from the Medical Capacity Act 2005. A person is not to be treated as if they are unable to make a decision unless all practical steps to help them have been taken without success. So that is, I guess, as an example, somebody with language difficulties, you'd have to make every effort to try and broach that language barrier. Somebody with another form of disability which required them to have some help to communicate, you'd have to take steps to engage with them to try and exercise the capacity that they have. A person is not to be treated as lacking capacity because they make an unwise decision. Apologies for the use of the he there, that's from the Act. The unwise decision thing is a really important thing. The whole point of the autonomy that the Act is trying to give people is to allow them to make their own decisions. Sometimes their own decisions do not align with what a doctor might do in the same situation, or what might be regarded as the best decision that a doctor would take or suggest that they take. But that's okay. Patients with capacity are allowed to make unwise decisions. It's often interesting that the questions we get on the advice line are from people who are faced with a patient who doesn't want to do what they think the patient should do. And therefore, they're starting to question whether there may be an issue with capacity in that circumstance. Of course, equally well, there could be patients who agree with what the doctor wants to do, but don't have capacity to make that decision. So it comes up most frequently when patients don't agree with what we want them to do. So sometimes they're making unwise decisions, but it also is something to be borne in mind when you've got a patient who is happily agreeing with what you want, but there may be an issue with capacity in the background that perhaps you haven't picked up on. This is a really important principle, the fourth one here, and it applies not just to doctors who are acting in a patient's best interests under the Act. It also applies to people who hold, for instance, a lasting power of attorney, which we're going to come on to for a patient. They also have to act in the patient's best interests. And there's a whole administrative process for things like LPAs, although not for advanced decisions, but for LPAs in place to ensure that people who have powers of decision making donated to them by patients are acting in the best interests of patients. So we often have calls to the advice line from people who are aware that, or who are concerned, probably not aware, concerned that people may not be acting in the best interests of a patient who lacks capacity. You know, that the elder abuse is a classic example of that. And there's a whole way of raising concerns about that. And this is a rather wordy final principle, and it's about making the least restrictive choice. So I usually try to illustrate this with an example. Just thinking, surgically speaking, if one had to do something for somebody who lacked capacity surgically, you would do the least invasive thing that you could do to achieve the same outcome as far as possible. And that applies to any decision that's being made under the Act. So moving on, let's imagine a scenario. You're doing a home visit. And if you don't work in general practice, it's okay. You can imagine it slightly differently. The information can be applied in different ways. The doctors report that the 72-year-old man that you've been asked to see has been confused at home. When you arrive, they tell you that he's taken a paracetamol overdose the previous evening. When you see him, the patient is disorientated and unable to answer questions. And the doctors report to you that he told them he would do this a week ago and rang to say that he'd overdosed the night before, which might raise some questions in your head as to why they hadn't brought it up before, but anyway. He had told them that he didn't want any help to be called and didn't want to go to hospital. And he's not attended the surgery in the past year, his only history being of high blood pressure and benign prostatic hypertrophy. So it's a scenario that clearly pulls together lots of different things to think about, but there's a fundamental issue here of a patient who seems to have done something perhaps to themselves, has made a statement about what they're looking for as a result of this and what they don't want to happen, apparently, and who's not able to engage with you about how they should be managed. So how do you approach that sort of thing? Well, we have to try and think about it in a structured way, and this is the sort of structure that I might apply if you called the MDU out of hours with this sort of query, which we do get. So the first question is, does the patient have capacity? And then we've got to go down the line of working out how one assesses capacity in that situation. Next question is, has the person appointed a proxy decision maker, or has a proxy decision maker been appointed for that person? So that might be somebody with a lasting power of attorney, or it might be somebody who's a court-appointed deputy. Are either of those people empowered to make decisions for this person? The third question is, has the patient already decided what they want done if this occurs? So is there a valid and applicable advanced decision? Advanced decisions are one of the areas in which English and Welsh law differs from other parts of the UK, particularly Scotland. So we will talk about advanced decisions in a little while, but it's a sort of special part of the Medical Capacity Act that does not apply in Scotland. But anyway, it's an important question to ask, is there an advanced decision which is relevant here? And the fourth question is, what is in the patient's best interest? So thinking about this patient's disorientated. We can obviously ask, which might give you a clue, and he's not communicating, which gives us a clue about his capacity. We can ask about the proxy decision maker. We can ask about the ADRT, or the advanced decision to refuse treatment, and we can think about best interest. So let's take those forward. The Act talks about how one assesses capacity, and it talks about a two-stage process as summarised in the Code of Practice. The first question being, does the person have an impairment of the mind or brain, or is there some kind of disturbance affecting the way their mind or brain works, whether it be temporary or permanent? And if so, does that impairment or disturbance mean the person is unable to make the decision in question at the time that it needs to be made? So a basic statement of the test that is applied. Clearly, that test is not to be influenced by a person's age, appearance, or any underlying condition or aspects of the behaviour that may lead to others to make unjustified assumptions. So remember, we're assuming that they have capacity. So that's the test, but actually what often happens is that you're presented with a decision being made by a patient, or apparently being made by a patient, and then you think, well, that's a really odd decision. Why is that happening? Or does this person really understand what's going on? You're picking up some information in the history or from the relatives that makes you think that the sort of guileless appearance of agreement with what you want to do or disagreement with what you want to do is actually an indication that all may not be well. So what then do we mean by make a decision? In what way can people make or not be able to make a decision? Well, the important questions are whether, of course, they can understand the information relevant to the decision, and that includes information about things that are relatively reasonably foreseeable consequence of deciding one way or another. So do they understand that if they make this decision, that might happen? So they've got abdominal pain, you think they may have pancreatitis and they want to stay at home. Do they realise what might happen? They have a chest pain, which has been going down their arm. You think they need to come into the hospital for further assessment. They've been vomiting, they're sweaty, they're not feeling great, but they want to go home. Do they understand what is actually going on? Importantly, are they able to retain that information? Do they remember what you've told them? Can they weigh up the information? Can they use that information as part of the decision-making process? And can they communicate their decision to you? If any of those 4 criteria are not met, they can't make a decision, and therefore they will not have capacity. And this is here, understand the information, retain that information, use or weigh up, and communicate their decision. A person is not to be regarded as unable to understand the information if he's able to understand an explanation of it given in a way that's appropriate to his circumstances. So what that means is you're not expecting them to understand at the level that you understand it as senior clinicians or as experienced doctors. You can explain it in a simple way. You can use visual aids, but they do have to have some understanding of it enough that they can make a decision. As regards retaining the information, this is a question that comes up quite often. How long should they remember it for? Well, we don't have that information to be able to relay it to you, but the fact that they're only able to remember the information for a relatively short period doesn't mean that they don't have capacity to decide. Because remember, obviously, people's capacity can be quite fluctuant, particularly through the day into the evening, as you all know. As I said, the information about the decision includes the foreseeable or the reasonably foreseeable consequences of it, of deciding one way or the other, or of not making a decision at all. And all of those are important things they have to understand. So putting the decision off, not answering the questions, not deciding, will have consequences, we know as doctors. And similarly, deciding one way or the other about how you want to manage the issue, similarly, will have consequences for that patient. So one of the questions I asked there was whether or not there was an appointed decision maker. So that's the lasting power of attorney, which for our purposes is generally a health and welfare power of attorney, or whether there's a court-appointed deputy. The questions don't actually stop there, though. It's not about whether there is a decision maker. Well, there is a decision maker, it's for them to make. That's not how it works. You have to know that the decision is within the authority. So has the patient gifted them the requisite authority to make a decision in this particular situation? Has the court given them the power to make a decision about this particular situation? If not, the mere fact that there's an LPA in place, if it doesn't apply, doesn't mean that they get to make a decision. And then importantly, are they acting in the best interest? And that's crucial because, as I said at the start, we're all aware of this idea of elder abuse. We're all aware of people who are vulnerable being abused by carers. And when you hold a lasting power of attorney for somebody, you have access to a lot of information. You've got access to potentially their money, them in a vulnerable state. So it's really important that they're acting in the best interests, and it's something to be thought about. So as regards lasting power of attorney, an attorney has got no power to consent to or refuse life-sustaining treatment unless the lasting power of attorney specifically states that it covers that type of decision. Importantly, LPAs don't give attorneys a power to demand particular treatments which doctors feel don't believe are necessary or in the patient's best interests. When might an LPA not be active? Well, if a patient makes an advanced decision which refuses a particular treatment afterwards, so they've done their LPA and then they make an advanced decision afterwards to refuse a particular treatment, then the attorney can't override that because the patient's made it clear what decision they would make. And of course, if there's an urgent decision to be taken with a patient who has an LPA and there's no ability to contact the person who holds the LPA, then it's appropriate to crack on and treat the patient in their best interests in the meantime. This is a woman called Joy Tompkins. She was an 81-year-old. She already had a valid advanced decision saying that she didn't want to be resuscitated if she had a hospital cardiac arrest. Interestingly enough, not only did she have do not resuscitate on her left chest there, she also had PTO, or please turn over, on her right shoulder, so people would remember to flip her over and check. But she was 81, and she said she didn't have the stamina to enjoy all her hobbies anymore. Her hobbies being playing the piano and gardening. Admittedly, this was 2011. I'm not sure if she's still alive now. It was 81. I couldn't find out if she's still alive. But DNA CPRs are another type of advanced decision if the patient's made it. So patients are entitled to decide to say in advance, I don't want to be resuscitated. They tend to be sort of less problematic decisions than advanced decisions of that type, or DNA CPRs made by doctors. Those are the ones that can give rise to problems if people don't communicate clearly about them. But this is an example of a very clear advanced decision. Although whether or not that advanced decision would hold up in law is a different matter. We're going to come on to advanced decisions and their validity in a minute. So what does an advanced decision do? An advanced decision enables somebody with capacity who's aged 18 or over to refuse, and I put that in italics on purpose because it's not to get treatment that they wouldn't normally have got, it's to refuse specific medical treatment for a time in the future when they lack capacity. What this person is saying is, I know that I'm going to lose capacity. When that happens, I do not want you to do this. In the same way that a patient cannot demand a treatment from you that it's not appropriate, an advanced decision can't say, I demand that I have that treatment. If it's refusing life-sustaining treatment, it must be written, signed, and witnessed, okay? And it cannot refuse basic care, which in this context would mean warmth, shelter, basic hygiene, and food and water by mouth, okay? The other things don't come under basic care. So peg feeding, for example, would not be basic care. It's also the responsibility of the person making the decision to ensure that it is drawn to the attention of healthcare professionals. Now, there's some other responsibilities which we're going to come on to, but that is important. The person who makes the decision should be drawing it to the attention of their doctor so that they understand that that is there. Advanced decisions are not still applicable when the patient is still competent, because they can make their decision clearly, where the treatment is not specified in the advanced decision, and where any of the circumstances specified in the advanced decision are absent, or if there are reasonable grounds to believe that circumstances now exist the patient did not or could not know. So in other words, things have moved on from when they made the decision 10 years ago. There's been a new diagnosis, new medications, radical changes in management or prognosis, or possibly evidence of a misdiagnosis, something that's changed the decision-making matrix that the patient was dealing with at the time that they formulated the advanced decision and had it signed off. It also wouldn't be a valid advanced decision if the patient had said one thing and then done another. So I'm going to try to think of an example of that. So they're saying, well, I have got an example from experience. Somebody's saying an advanced decision saying they didn't want to be vaccinated, but then so they've done this advanced decision, but then for years they were trogging off to the practice to have their vaccinations. So they were doing something which was in direct contradistinction to what they had written that they would not want if they lost capacity. So that kind of added a level of concern about the decision making in the advanced decision and whether it was an accurate reflection of what the patient actually wanted. Another example of when it wouldn't be valid would be if the patient, after writing or having an advanced decision recorded, then gave the power to somebody else to make decisions for them. That would raise a concern about the validity of the advanced decision. The NCA also talks about best interests. And when you are acting for a patient who lacks capacity, so if we go back to the scenario that we were talking about there, this is the confused patient who may have taken a paracetamol overdose. If you decided that the patient doesn't have capacity, then whatever should happen to that patient should be in their best interests. And when you're thinking about best interests, it's not just the medical best interests, it's the totality. You're thinking about everything that's relevant to that patient. And that might include, for instance, their past and present wishes, their beliefs and feelings, if it's ascertainable. If the patient is able to engage at all and to talk to you about it, then they should be encouraged to do so. And if it's practical, again, and appropriate, you should be involving their carers and those close to them. So what about emergencies? What happens then? Well, this is quite well covered in this chunky book here, which you can get online, the Code of Practice. It talks about, it says that from time to time, people who lack capacity to consent do require emergency medical treatment to save their life or prevent them from serious harm. And in those situations, the reasonable steps to take may be different from those non-urgent cases. Okay, it says at 6.35, the Code of Practice, in emergencies, it will almost always be in a person's best interest to give urgent treatment without delay. One exception is when healthcare staff given treatment are satisfied that a valid advance directive or decision to refuse treatment exists. So in emergencies, it's a best interest decision unless you know for definite there's an advance decision there to refuse treatment. You might, if you're aware there's a lasting power of attorney, you would be speaking to them. But if things are spinning quickly out of control and you need to get on top of the situation, you treat in the patient's best interest as far as they are ascertainable. Sometimes that might involve restraint, which is something that is recognized in the Act. And if the person taking the decision thinks that is appropriate and necessary to prevent harm to the patient, to a patient who lacks capacity, so it's not somebody who has capacity, but who lacks capacity, then that's okay, as long as the type of restraint and the amount of time it's used for is proportionate to the likelihood and seriousness of harm. So restraining somebody who is acutely delirious, who is at risk of harming themselves from falling out of off a trolley or from leaving the department when there's exceptional well may be reasonable in the circumstance. There is one case which I think is relatively interesting, which is to do with communication of advanced decisions. And this was a court of protection case to do with an 85-year-old former nurse called Gillian Rushton. Ms. Rushton sustained a traumatic brain injury in December 2015, and she was then had a prolonged period of disorder of consciousness. She lasted 3 years. But interestingly, in this case, a year before she sustained the head injury, she had created an advanced decision, specifically an advanced decision to refuse treatment, saying on collapse, I don't wish to be resuscitated by any means. I'm refusing all treatments. This is a nurse, remember, even if my life is put at risk as a result. In all circumstances of collapse that put my life at risk, this direction is to be applied. As I said, in December 2015, this woman suffered a major trauma. She had a nasty head injury. She was not expected to survive and was placed in a palliative care plan. On admission, as frequently happens, a nasogastric tube was inserted to feed her. When, contrary to what the neurosurgeons thought, she started to improve a little bit, the nasogastric tube was swapped over to a PEG tube, so a percutaneous endoscopic gastrostomy. And it was clear that the information that treatment really was a life-sustaining treatment, and that it was beyond what the patient had said previously that she wanted. So why did that happen? Well, one of the things that came up in that is that the patient had made the advanced decision, and as incumbent on them, they had let their doctors know about it. The hospital were aware there was an advanced decision because the family mentioned that there was one, so that the hospital called the practice to say, we believe there's an advanced decision. What is it? And you can see the record of the call there. It says the advanced, the record, it just says do not resuscitate. The GP's reported as having said they had no knowledge of any other document, when of course, but actually in reality, the document was much more detailed as to what the patient did not want done. Therefore, the PEG was inserted and the patient was kept alive in a minimally conscious state for some time. Subsequently, the Judge Hayden in this case, said that it was not a proper interpretation of the advanced decision and that should not have gone ahead. In other words, the patient should not have had PEG feeding. And this was in the decision from the court. It said where advanced decisions have been drawn up and placed within GP records, there is, and this is their quote, an onerous burden on the general practice to ensure wherever possible that those advanced decisions are made available to clinicians in hospital. And by this I mean, this is the judge saying this, I mean a copy of the decision should be made available and placed within the hospital records with the objective the document should follow the patient. Now, clearly, that is technically very difficult to do when there's a myriad of potential hospitals in some cities that people might go to. I think the point really here is that when you are asked about what an advanced decision is, you need to be clear as to what is in the advanced decision. You need to share the advanced decision with the hospital. I don't think it's about you trying to make sure that every hospital a patient might go into has a copy of the advanced decision. It's about sharing the relevant information at the relevant time when it is required. Also, encouraging patients to keep advanced decision with them, perhaps to give it to their families, to make sure their families are sharing it with other people as well, should that be necessary. And at this point, what I'm going to do is I'm going to hand over to John Dale Skinner, Dr. Dale Skinner, who's going to talk to you about some other aspects of capacity which come up and are sometimes asked about. John.
Thank you very much, Gerard. I'm pleased to talk to you all this evening about this topic because it's one of those topics on that list that I have that I wish I'd known more about it before I started working at the MDU. So I hope you find this part of the talk helpful. We're going to talk about wills and disputes, and I've started off with this scenario which some of you may have had a similar sort of request like this one in your own practice. So you're approached by a solicitor some 2 years after the death of a patient. You're advised that there is a dispute within the family as to the validity of a will made in the last 6 months of the patient's life. You're asked to comment upon the testamentary capacity of the patient in that period. You look at the records. The patient consulted with a number of physical health problems in that time. How do you respond? And what if you are asked to witness the will of a patient or to assess testamentary capacity? So should we start off with some very basic terms? We've used one there, testamentary capacity. So that's the capacity or the understanding required to make a valid will, and the testator is the person making the will. So we'll move on to the next slide, and I think it's our experience at the MDU, and you may feel the same, that there's probably an increase in the number of requests that you get about this, or that they're becoming more common. And what's the reason for that? Well, I suppose we're dealing with an increasingly aged population with complex comorbidities. So more people are living longer with conditions which may be affecting their capacity to make a decision about their will. There are changing family dynamics. So in the past, there was often a very simple way that somebody's estate was to be handed down to the next person, whereas of course we know now that people might be no longer living with other people in the same household, families split up, people move away, so lives are perhaps slightly more complicated in that regard nowadays. And I think generally there's an increased awareness, certainly among the health profession, but also amongst the general population in terms of capacity, and asking the question, does this person have capacity? So if we move on to the next slide. So as Jerard said in the previous slides, mental capacity is time specific and decision specific. But in terms of testamentary capacity, there are other things that we need to consider. And the main one is this case of Banks versus Goodfellow, a historic case which you may have heard of before. It is an English case, but it is a touchstone in all the jurisdictions, including Northern Ireland. And this case referred to a patient with schizophrenia who passed his sizable property estate to his teenage niece. Now, following the death of the niece, who'd inherited this estate, other family members challenged the will because her estate ended up being passed on to somebody who wasn't a relative of Mr. Banks. And so we've got this case law that guides us in how we consider such a request to assess someone's testamentary capacity. And the outcome of that case was that it concluded that the validity of the will was not affected by the partial unsoundness of the testator's mind. So the fact that Mr. Banks had schizophrenia was not necessarily a reason for the will being invalid. But as long as the testator understood what he was doing with his property and affairs at the time that the will was drafted and executed, then the will was valid. So if we look at that in slightly more detail, how can a testator demonstrate this capacity, and what things do we as doctors need to think about asking about? And so the testator must be capable of understanding the nature and effect of making a will, the extent of his or her estate, the claims of those who might expect to benefit from the will, and they shouldn't have a mental illness that influences him or her to make bequests that he or she should not otherwise have made. So when a doctor is having to assess somebody's testamentary capacity, they will need to have certain bits of information that you wouldn't normally come across in your clinical work dealing with a patient, but you do need to make inquiries to ask, for example, the extent of their estate, and you may need to ask questions about the people who may benefit versus the people who won't, and what the patient thinks about that. So if we move on to the next slide, you may sort of question at this point, why does this come across your desk? So a patient, an individual will instruct a solicitor. Why does the doctor need to get involved? And we actually have this case, Kenwood versus Adams 1975, to thank for that. So this case talks about a golden rule for solicitors. So it is good practice for a solicitor who is helping a patient draw up their will to seek a medical practitioner's opinion if the testator is aged, so if they're elderly, or if they've suffered from a serious illness. And so it's best practice for a medical practitioner to be satisfied that that testator has capacity and understanding, and that that is recorded and preserved if justification is required in the future. So if we move on to the next slide, we talked about the law that we need to consider as doctors if we receive a request like this. But of course, as doctors, we have our ethical obligations and the GMC guidance, a good medical practice, which fits in very nicely with the laws that we've been talking about, and that's recognizing and working within your limits of competence. And it's also documenting your work clearly, accurately, and legibly, and ideally contemporaneously, so at the same time of the events that took place or as soon afterwards. But furthermore, in the GMC guidance, if we turn to the next slide, the GMC guidance states that doctors should be honest and trustworthy when writing reports and when completing or signing forms, reports, or other documents. And we mustn't write anything that's false or misleading. And A and B is quite important here. So you must take reasonable steps to check the information is correct, and you must not deliberately leave out relevant information. And what we know about is that those cases that we discussed earlier, there is certain relevant information that a doctor is expected to consider when assessing somebody's testamentary capacity. And so when you are doing this, you need to be sure that you can demonstrate that you've taken reasonable steps to do that. And so I suppose the tips for approaching a request like the one that we started with in that case study is obtaining sufficient information from the solicitor. This is not something that is simply going to be you're simply going to be able to do in 10 to 20 minutes. You may need to request further information from the patient or their solicitor, and you need to set aside sufficient time to assess the patient and then record your assessment. And as we're obligated to provide a clear and detailed contemporaneous note of the assessment, and that might include quoting specifically what the patient has answered to specific questions about, for example, who might benefit the will, who might have an issue with the will. It'd be important to include who else was present and to consider the extent of the estate and, as I've said, the potential beneficiaries. So if we turn on to the next slide. So in terms of beneficiaries, I suppose this is where these things can come out of the woodwork when people find out that they haven't been included in a will, or in fact they were included but they've now been excluded. So it's always important to check about previous wills and to check whether other people or people are now being excluded. And that can also help you as a doctor to assess a patient's impairment of memory, their reasoning or their judgment when they're explaining why they've made a decision to change their will. And of course, it seems quite obvious, but take special care if it becomes clear that close family members are being excluded. It'd be important to record that in detail, the patient's reasons for that, because those are the sorts of cases which may cause some problems and some questions in the future. So if we move on to the next slide. So in summary, testamentary capacity, often fairly straightforward. You as GPs know your patients very well, probably better than many of the other clinicians who seeing the patient. And as GPs, we always want to help our patients, and we want to try to facilitate a request like this. But as I hope I've discussed today, there are certain things to consider when you receive a request to assess someone's testamentary capacity. And so if you're in doubt, it's reasonable to say so, to seek a second opinion from another clinician. It may be, for example, that the patient is followed up by the memory clinic and there is a geriatrician who might be helpful. But it is also open, if you are unable to help the patient, it's open to the solicitor to instruct an independent expert, for example, and particularly those cases where it is finely balanced. It may be that you can't actually agree to the request. Of course, flatly refusing a request without giving a reason can be cause an issue with a patient who might have that expectation that you should be able to help them with it. They may have been told by their solicitor, for example, that your friendly GP can sort this out for you. But even if you are declining the request, explaining your reasons and why it's a finely balanced thing, why it's so important to get it right, can sometimes help a patient understand that. But of course, with those finely balanced cases, or if you've got any queries or concerns, you can always phone us on the MDU advice line or contact us via the online reporting of cases, and we'd be happy to help you as well. And there's a final slide here, retrospective requests for a report. So you may receive similar requests like this. So you have to be clear that you haven't assessed the patient's testamentary capacity at the time, but of course you may be able to provide a medical report which sets out factual and descriptive account of the relevant time period, where somebody may be investigating whether somebody who has made a decision about their will, you might hold information that can assist in inquiries about that. But of course, it will be for a different process to determine what they make of it and the patient's testamentary capacity. But of course, as a GP, you might have information that can be helpful, some factual information which can be provided.
Thanks very much, John. That's quite a common call to the advice line, isn't it? With people demanding that post hoc the GPs or comment on somebody's testamentary capacity because they've just become aware that somebody else has changed the will, and that's a very difficult position to be in because, as you said, given the detail required for testamentary assessment, capacity assessment, it's highly likely that will not have been done unless it was specifically requested. Anyway, thank you very much for doing that, John. I'm going to ask you to hang around now. I think Ed is still gathering questions in the background. So in summary, we tried to put up a sort of a systematic approach to how you deal with these questions of capacity, the things that you need to think about. I've highlighted the importance of communication. In fact, a court case related to a failure to adequately communicate, in part, it wasn't all about that, but in failure to adequately communicate information about an advanced decision. And we've highlighted something to do with requests for reports, which come frequently and sometimes are very difficult to deal with. They require a lot of time, and certainly incredibly hard to do anything valid in a report in a sort of retrospective fashion, as John has illustrated there. And now I think we're going to come on to some questions. Ed, are you
yes,
have some questions for?
First of all, thank you everybody for some really interesting questions. We've got loads that have come in. I'm going to maybe start at the end because I think there's a few things that have come in about testamentary capacity. One that I'll deal with is, I can see a comment here that we're surprised that the MDU are talking about testamentary capacity as it's not in the remit of GPs. I'm afraid it is. It's not something you have to do if you don't feel able to do it. But lots of our members get requests for assessment of testamentary capacity and reports in general practice. A couple of other things, John, there's a question here about is undertaking capacity assessment for, or testamentary capacity assessment, is that NHS work, or is it something that a GP can charge a fee for?
So it's not NHS work, and it can attract a fee, and that would be in line with what your practice fee list is. And so of course it is always important to check with your practice whether you're contractually obliged to complete reports like this, but there isn't it isn't part of NHS work, so can attract a fee.
And I think it's certainly in some instances a GP will be very well placed to provide a report in this type. In other cases, they may not and may decline the request. And a lot of it is really about having accurate instructions and adequate information from the solicitor as well for a GP to feel comfortable going ahead. So turning to the capacity questions, we've got the issue here in terms of where do we stand legally as emergency department practitioners, and this is, I apologise, a pastiche of several questions that have been raised about people who've taken overdoses. Should you respect the patient's autonomy? What happens if the psychiatric assessment is delayed, etc.? What do you say about that, Jerard?
I think that there's quite a lot of writing about this. Something a lot has been written from the department, from the College of Emergency Medicine, and from in collaboration with the Royal College of Psychiatrists as well. I mean, I think there is a presumption, or at least it's reasonable to start off with the idea in your head that it's easier to save a life and then apologize for that than it is to deal with the issues that arise from failure to engage with somebody and try and manage their condition. I think that the patients who are severely depressed to the point of trying to take their own life, there's a very high chance that their capacity to decide is going to be impaired. There may be an interaction, and interactions can be quite complicated with the Mental Health Act as well. So I think that the mere fact that somebody has taken overdose and is refusing doesn't mean that that's the end of it. I think it's really important that people make a very thorough assessment of that person's capacity, and given the complex interaction with the Mental Health Act, that they engage with, they get the psychiatrist in it, and if there's a delay in the psychiatric assessment, that they get on the phone to the psychiatrist and say, I need you to come and assist us with this patient now. And I've worked in A&E, so it's not as if I'm saying this without any experience of having been in that position of saying we need to make an urgent decision about this patient. And obviously it's complicated because often these patients will have, taken the drugs and then called an ambulance, or taken the drugs and then turned up in hospital. So there's mixed motivations and things there. Ed or John, anything you want to add to that? It's a difficult one. It's the sort of call we get in the middle of the night.
I think that it's really complicated because it's got several overlapping things. Whether a patient's taken an overdose or not, the assessment of capacity remains the same. There is protection for taking urgent action to save life as needed in that time whilst those issues are resolved. And I think some of the other issues that are raised in terms of whether it's their mental states, etc., and an ability to assess that, and whether they should be detained for that reason, of course, engages the Mental Health Act and the interface between the two, and clearly that there may be some circumstances where you can apply an emergency detention before a patient is assessed by a psychiatrist, otherwise not. There's another couple of questions here that I just want to touch on, because I think this is a really important question to get across. There's questions here saying, could you please provide examples of the specific questions when asking their capacity, and a linked one which says, look, can we use the mini mental state assessment to assess capacity? And think about this in a conceptually different way. If someone's got a really low mini mental test score, that might definitely raise a question about capacity, but it doesn't determine it. Remember that capacity is decision and time specific, and so you're going to have to explore the patient's ability to understand information relevant to the decision, their ability to weigh relevant things in that context, and to communicate the decision to you. And the questions will vary on each occasion for that. And of course, you've got to think about how you can maximize the support for them to do that. So I'm really sorry we can't tackle that in detail, but that's really interesting.
We think about it as also in terms of, you imagine going around a ward with elderly patients on it. Many of them may well have a low mini mental state score, but you still wouldn't override their decision making for lots of their day-to-day decisions that they might make, what they're going to wear, what they're going to eat. You still ask them those questions, so it's not any different, really. You still have to assess their understanding of the specific situation at the time it needs to be addressed.
So there's a couple of other quick things here. Is feeding PEG or nasogastric feeding a type of treatment? I think it's fairly well settled now that clinically assisted nutrition and hydration does count as treatment. So yes, it does. And John, there's a question here.
In the slide specifically, Ed, I said that food, receiving food and water by mouth was basic care.
Whereas assisted nutrition is a form of medical treatment. We also have a question here saying, as GPs, do we have to fill out a form when assessing mental capacity, or can we just document in the notes? Also, is there a fee when completing paperwork for it? John, do you want to comment on that?
Yeah, I think it goes back to your answer, Ed, in terms of are there a series of questions that you can ask? You know, trying to think of it like a pro forma, and is there a form we can complete, may not actually be that helpful, because you want to make sure that your discussion is specific to the decision that you're looking at, and also the patient's circumstances. So it's certainly not mandatory to have a template to set this out on, but it's important that you capture in your notes of that conversation all of those elements that are the framework of that discussion, which Jerard talked about.
I'm conscious we're really coming up to time, and the question about a fee, it really depends. You know, there are some limited things that you can raise a fee from your registered patients about, and some forms of medical reports are part of that. But remember, you're assessing capacity all the time. When you see someone and think, look, you know, I can have a reasoned discussion with them about a plan of treatment, they can consent to taking a prescribed medication, you've made an assessment of a capacity for that. So remember, this is part of routine practice. And I think the thing that I'm really sorry, we really, I think, aren't coming up to time, is that there's a lot of discussion here about the interface between the mental, you know, the impact of a person's underlying mental disorder on capacity. And those are the circumstances where one might need a specialist opinion. You know, everybody is duty bound to assess capacity when they are making treatment, when they're providing treatment or care for a patient. But there are some instances where you would need to bring a specialist in, and particularly I've got a comment here about a colonoscopy scenario, etc. With that may well be the case that you need some specialist input.
Yeah.
So
I think that raw bleeding edge of the Mental Health Act and the Medical Capacity Act, that's a complex interaction, and there are lots of sort of academic papers written about it, and that's when I think, as I'd said, you may well require somebody more specialized to offer an opinion.
So Fantastic, everybody. We're up to time. I am so sorry we didn't get to all your questions because there are some really interesting concepts in there. I'm really grateful for you spending the time with us this evening. Lots of people are asking about the slides. We will have the webinar recorded and available on our website, hopefully within the next week. So thank you so much for your engagement tonight, and have a good evening.